Hello, Dr. Makkar, how are you?
Good.
Okay.
Praveen.
So, welcome to the city of Mumbai, to India, back again your own country. I am Dr. Praveen Chandra. I am interventional cardiologist from Medanta Medicity Hospital, Gurgaon. And with me is Dr. Makkar, who is one of the biggest exponents of structural heart diseases in the world. And he's presently the chief of cardiology and interventional cardiology at Cedars and Eye Center in Los Angeles. So welcome, and I'm sure you are going to tell us so many things about this new upcoming field of structural heart disease and specifically transcatheter aortic valve implantation.
Pleasure. So I think as you mentioned, TAVI is one of the most exciting areas today in interventional cardiology. I mean, the concept was introduced by Henning Anderson almost 30 years ago, and Alain Cribier did the first procedure 15 years ago. And in the US, the field has matured because the FDA approval, which occurred about 6 years ago, has led to quite a dramatic adoption of this technology. But I do see that there's a lot that still needs to be done in India. I mean, where the TAVI is still in its very infancy. And it's true that even in the United States, though we are doing a lot of procedures, and though now, in fact, we have exceeded the number of TAVI procedures that are done in the United States exceed the number of surgical aortic valve replacements that are done. And in 2017, there were 52,000 TAVR procedures done. But these procedures are being done in patients who are not surgical candidates or in patients who are at intermediate risk. But nonetheless, we still don't know, and there is not much adoption, rightfully so, in absence of data in patients who are at low risk for surgery.
Good. So that means that the indication of this procedure is expanding rapidly. It started from very high risk patients, and now as we see the data, it is coming up with patients who are at very low risk, and those patients who are young patients, those patients who are in the range of about 65, 70 years of age. Because in India, the issue is that compared to the West, in West people are very, very active up to 80, 85. In India, people start feeling old at the age of 65, 70. So do you envisage or you see that this indication of TAVR can be easily used for our patients who are in the range of 65, 70 and they do not want surgery? Is it okay to do that?
So Praveen, I think you raise a very important point. You know, low risk for surgery doesn't necessarily mean that these are young patients. For example, the NOTION trial, which was done in patients who were low risk for surgery, you know, the average age was still in mid-70s, though the STS score, the risk for mortality from surgery, was less than 3. And the same thing holds true, for example, for the low-risk study which was done in the United States. It was a registry done by Ron Waxman, where, once again, the STS, or the risk for surgery, was 1.9, but the average age was still about 72 or 73 years of age. So I think it is important to differentiate. So there is data for low STS risk, all right, which comes from the NOTION trial, that the outcomes were very good, all the way up to 6 years. It's not a very large study. It's actually a small study. The 2 large studies in low-risk patients have been completed, the Medtronic study and the Edward Sapien 3 study, the Partner 3 trial. You know, together there are about 2,500 to 3,000 patients in these studies, and they're going to be presented at the ACC. So I think from that we'll gather substantial amount of data on the low-risk patients. But you're mentioning about the young patients. And the question is, do we have data to do this in young patients? Well, the first thing that supports it is, for example, in the Ron Waxman low-risk trial in 200 patients, the mortality was 0, stroke rate was 0, pacemaker rates were only 5%, and more than moderate aortic regurgitation occurred only in about 0.5% of patients. These are very good results, in fact. So I think clearly And 80% of these cases were done without general anesthesia under conscious sedation. So I think not only were these results impressive, but they actually were done at multiple institutions, and they were not all high volume centers. All right. So I think it is feasible to get acute results that are really superb. The question arises about the durability of valves. So can we use this technology in patients who are young without really knowing a whole lot about the long-term durability of valves is the key question, right? Now, there are some interesting concepts that have been floated around about using this in young patients. And one of the concepts is that you could make an argument, this is something that has been popularized by Michael Mack. It's a very thought-provoking concept. Why not start in a young patient with a TAVI, all right? Do another TAVI maybe 10 years later, and then 20 years from the time of the first procedure is when that person could actually have a first open heart surgery, and then 15 years after that, maybe he can have a TAVI in that surgical aortic valve, all right? Rather than starting with a surgical aortic valve replacement, having 2 TAVIs in that, and then needing a reoperation around the same time. So I think it's a little out-of-box concept, and I think that I will not be surprised, especially in India, if you start to see this technology being adopted in younger patients.
Okay, so this is about the indication. So let me just simplify for our viewers that, because most of the viewers will not be actually knowing all these terminologies of STS score, etc. So the indication of doing a percutaneous valve, or which is known as TAVR procedure, which is a non-surgical replacement of the aortic valve, is clearly indicated for patients who are above the age of 70 years and are having severe symptomatic aortic stenosis. And also, as Dr. Makkar mentioned, that it can be used in patients with the data which is available where even surgery is indicated, but this procedure can be done. But definitely, it is not the first procedure of choice for patients who are below the age of 50 years or 55 years. So that is the situation right now. And for rheumatic heart disease patients, what do you say? Because we have a lot of rheumatic heart disease. So patients come with just aortic valve disease with mixed aortic stenosis and aortic regurgitation. So you have to say something on that. Can we take these patients up, or we have to still select a few from them?
Yeah, so I think that once again, I think technically there is nothing that would prevent us from using, for example, balloon expandable or self-expanding technologies in patients with rheumatic heart disease. It so happens that a lot of patients with rheumatic heart disease happen to be young. So I think you have to take that into account and see what is the best treatment for them. Is it surgery, or is it transcatheter aortic valve replacement? And I think it's important for me to clarify. I think what I was talking about earlier is that I will not be surprised if it is used in young patients here, which is a little bit different from having data in very young patients. I think that data is still lacking.
Yes. Yes. Yeah. So this is very clear that you said that this technology is expandable. It can be used in a very wide spectrum of patients and is safe. So the safety has been now compared with surgery in all subset of patients. It has been checked against medical therapy also. So this is a safe procedure. So tell me, what are the routes through which we take this valve inside? Is it the femoral artery only, or we can do it from some other locations?
So I think you get the most bang for the buck, as you can say, when you use the transfemoral approach, because it is one of the safest approaches. In the early days of transcatheter aortic valve replacement, transapical route was often used. It's a minimally invasive surgical approach, and so was the transaortic approach, where the surgeons made a small incision in the aorta and then we introduced the catheter valves. But these approaches have really fallen out of favor.
Okay.
The device size, the catheter size has actually come down significantly. So 90+% of the times, in fact, you're able to do this procedure using the transfemoral approach. Now, one of the other approaches that has substituted for the transapical and the transaortic approach is the subclavian or transcarotid approach. So I would say in the United States, in the TBT registry, the use of subclavian and transaxillary approach is about 3%, while 95% of these procedures are being done using the transfemoral approach. There are other interesting approaches, such as the transcaval approach, where you actually enter the vein and make a hole and enter into the aorta above the bifurcation, and then sort of do the procedure through the sheath that has gone from the vein into the artery. But nonetheless, that requires special expertise and learning.
So in your lab, I know and I have seen also that this procedure is done like simple angiography and angioplasty, which is phenomenal. The way it has progressed and the training which comes with experience has led to you the situation that you can do this procedure in 15-20 minutes.
Well, yeah, I mean, I think that things are simple till they are simple, right? And then when we have issues, we have to be very careful. So I think what you've seen in our lab is a culmination of, or a result of the experience we've had with more than 3,000 TAVR procedures over the last 10 years. So it's very important, though, not to forget that this is a team effort. It's a hard team approach that is absolutely critical. Imaging is absolutely critical. You need a very expert imaging person. You need a good anesthesiologist that can work with you to get these procedures done. Not necessarily with general anesthesia, but with conscious sedation and local anesthesia, but be there in case it needs to be converted to general anesthesia. So yes, you can do multiple procedures. You can do up to 8 procedures in 2 labs, and occasionally we've done 10 in a day. But nonetheless, I think it's important to have a very dedicated group of people that are committed to doing this procedure very reliably and reproducibly in a safe fashion.
So you mean to say the heart team concept is supreme in this case?
Absolutely.
And a cardiac surgeon in US, they have to be in the lab or around when the case is being done. But is it necessary for the heart surgeon to write on the file that this case can be taken for a TAVR procedure? Do we need a clearance from them or really not?
In the United States, CMS is the body that approves the reimbursement, and the CMS has mandated that the surgeon certify that the patient is either high risk or inoperable or intermediate risk.
So when the patient can go both ways, is there a fight between the surgeon and the cardiologist?
I have to say that those things have dwindled away.
Okay.
At least at my hospital, we have a very collaborative environment. And I think people have come to appreciate each other's strengths. And I can tell you that the heart team approach has really made our program much stronger. And in fact, it's increased our volume.
So this is a very...
For TAVR and SAVR procedures.
So this is a very important ingredient to start a TAVR program, that the heart team should be a good heart team. They should understand each other. They should know the strength and weaknesses of each other. And then only you can give good results to the patients. Is that right?
That's correct.
Okay. And now, it appears that the TAVR is good. It has good results. The durability is good. And the long-term follow-up, the longest follow-up patient you have is how many years? 10 years?
Well, we started doing TAVR 10 years ago, but we were doing these procedures early on in patients
in the studies,
were not going to survive that long, where we knew that their valve was going to outlast them. But we have a few patients that are 7 years out and 8 years out.
And the gradients are okay?
And the gradients are okay. But we've also seen a few patients that have actually had an increase in gradients, and where we went back and actually did a repeat TAVI procedure in them. So demonstrating that you can do a second TAVR in the first TAVR.
So do you get some sense of the durability? Because in the same time span, you have been doing surgical valves also with the prosthetic, these bioprosthetic valves. Yeah. So do you have any idea of how both are comparing to each other in terms of durability?
I think the whole issue of durability of surgical valves has been misunderstood, because durability of surgical valves has not been looked at very rigorously. Traditionally, in the earlier days, the definition of a durable valve was freedom from reoperation. So you could have a valve that is degenerated, But if a patient doesn't come for a reoperation or is not good enough for a reoperation or is dead, it qualified as freedom from reoperation. So I think now we have uniform definitions that are going to be applied to TAVR
because many times
and surgical aortic valve
patients ask that whether my valve, which is done through the percutaneous approach, will be as good as the surgical valve. So, what is your answer?
So Praveen, this is what I tell them. I tell them that we have data now up to 6 years in randomized control fashion, and if anything, there is no difference, and if anything, the hemodynamics or the valve areas are actually larger with the transcatheter aortic valves than they are with the surgical valves. I will also tell my patients that the transcatheter technique allows us to put bigger valves compared to the valves that are actually put during surgery, because during which time patient's heart is on a heart-lung machine and the heart has shrunken. So it is harder for a surgeon typically to put a larger valve. For us, when we're doing TAVR procedure, the heart is expanded and we can put much
take
larger
a bigger valve.
So this diminishes the risk of what is called patient prosthesis mismatch. All right, so I think that's another advantage. And we can also tell our patients that the way we've looked at surgical valve durability has been somewhat flawed. And in fact, I often tell them that I'm using TAVR procedure for patients who have failed surgical valves. And guess what? In the VIVID registry, 20% of the patients with degenerated surgical bioprosthetic valves that were treated with TAVI procedure or TAVR procedure were actually done within 5 years. All right, so I think that is a glimpse of the flawed method in how we've been looking at surgical valve durability. All right, so if there was no TAVR, most of these patients would not come back for a procedure, and these valves would be considered to be durable.
Good. So which means that this procedure is very safe, very, very effective, and can be used for a large number of patients. Now the last thing about the cost of this procedure, because in India cost is a big issue, not everybody can afford this, and there are not state-funded agencies to support this. So do you think that the cost is going to go down, and what is your crystal balling for the cost of it? Because we have now Indian valves which are in the pipeline now. So
yes. So I think let's talk about cost. So in the United States, the Medicare reimburses this procedure. All right. So the patient is not charged any significant amount of money. But even in the United States, according to some studies, only 1 out of 8 patients with severe aortic stenosis undergoes aortic valve replacement, either by surgery or by transcatheter aortic valve replacement. So clearly there's a disconnect from the data that we have that clearly shows that aortic valve replacement saves lives and the number of patients that are actually being treated. So even eliminating the cost factor, there is a disconnect, and I think we need to work on that in terms of spreading the message that this is technology that should be utilized more often.
And it is a cost-effective technology, which has been proven.
That's correct.
And so now let me tell you that in India we have now crossed about 600 valves, and in our own center we have done the fastest 100 in India of these valves, and really the patients, I can tell you, vouch for them that the experience has been really good. They feel very good, and they really feel that there is a cost effectiveness in terms of getting this procedure done for themselves. And with this, I can also let you know that the 2 Indian valves which are being tested at this time, and they are also doing very well. So it will bring down the cost quite dramatically.
I agree with you, Praveen. I think with the large number of patients that India has, it is important for the cost to come down. And I think that once you have the cost come down, you're going to be doing a lot more procedures than any other country. So this is the bottleneck, and I think it's exciting to have indigenous technologies that are being developed, which will hopefully result. And I've challenged these companies to actually reduce the costs so that this technology can be made available in a widespread fashion.
Thank you, Dr. Makkar, for these wonderful inputs and your experience we shared with us, and also your help you have been doing for the treatment and for the this therapy being advanced in India. Thank you very much for being here.
My pleasure, and I'm committed to helping and growing transcatheter valve therapies in India.